Okay, going to try to do a quick overview of DVT. A lot to cover here, but I'm going to try to go through a little bit of what we're thinking when we're setting up the case, and then a lot of the kind of logistics in terms of what we're trying to accomplish during the case. And so we'll start off and just give an overview of DVT and the anatomy. And so for the purposes of this discussion, we will break the anatomy down into three segments. And so the IVC, which is roughly from just below the belly button up to the heart, the pelvic veins, which are below down to the hip, and then below the hip, which I'll call the leg here. And so IVC, iliac veins, and femoral and popliteal veins are really what we're referring to. And so when we break down how DVT affects patients, and so it's important to start off and have that discussion and talk about the valves and the different systems. And so what you have in the leg, let's say, for example, starting in the leg segment, femoral popliteal segment. So you have a network of deep veins. And the deep veins I refer to patients when I describe this as like the interstate system for bringing blood back from the foot. So all of this venous blood is returning from the lower leg, and it's heading up this pathway. These deep veins are larger. The femoral vein is about the size of your index finger in diameter. They also have a lot of supportive connective tissue. So they're surrounded by muscle and fascia in a way that they're very well supported, almost like they have their own compression stocking, you could say. And they also have robust valves. And the valves are one-way doors that open up in an effort to counteract gravity and keep blood flowing in the right direction against gravity. And so the deep veins are like the interstate system. Well, if you have an interstate, you kind of have to have highways and back roads. And so the highways and back roads are what I think of as the superficial venous system. And they are more numerous, just like the interstate back road parallel. There's almost an infinite number of these veins, and they form a network of veins that are not really designed for high traffic, so to speak, but they are important if you end up with a blockage in the interstate system or in the superficial veins. And so when we look at what we're trying to accomplish in treating a patient with DVT, it's clot in the interstate system, but what we are really trying to accomplish is preventing a syndrome that occurs in the 6-month to 2-year window following the DVT called post-thrombotic syndrome. And post-thrombotic syndrome, or PTS, is basically chronic circulatory compromise from having high pressure because you're not efficiently moving blood back from the foot. And so to break that down, there have been a few studies. One in 2016 showed that the deep veins from about the thigh down can be compensated for if they clot off by the network of superficial veins, which enter just above that. And so if you end up with clot that extends to or above the hip joint in that common femoral segment, the patient's at jeopardy for having both the superficial veins and the deep veins obstructed. And if you end up with obstruction of the deep and superficial veins, then you run a lifetime risk of developing progressive symptoms that can lead to post-thrombotic syndrome. And you may say, well, what does that do? It causes chronic pain and swelling, it causes skin discoloration, and over time leads to skin breakdown and chronic non-healing wounds. And it's a real big wound care issue and quality of life issue for a lot of these patients. So if it extends to the common femoral and above segment, we know, hey, these are patients that we more than likely are going to treat. If it's very symptomatic on presentation, then that can indicate that there are other risk factors at play, even if it doesn't extend into this common femoral segment, that can put the patient at risk for PTS. So a femoral popliteal clot that's very symptomatic on presentation indicates other risk factors usually, and that can be a stenosis in the IVC. It can be more commonly truncal obesity with increased intra-abdominal pressure because of obesity. It can be diabetes and chronic lower extremity swelling and just generally poor circulation. And so those patients who have femoral popliteal DVT are a bit of a gray area. We don't treat all of them. We actually treat few of them. But if they present with severe symptoms in just the femoral popliteal segment below the superficial vein inflow, then those are patients that may get treated as well. And then what we see not uncommonly is a process on the left leg called May-Thurner. And May-Thurner involves the aorta branching into the pelvic veins that head down to the foot. And that right-sided vein crosses over, the right-sided artery crosses over the left-sided vein here. And that's an iliac compression syndrome that over time, the artery sits on top of the vein and creates a chronic thickening or reaction in the wall of the vein, which makes it less distensible and slowly constricts flow through the vein. And so that process over time is called May-Thurner. And it affects a lot of patients, the minority of which end up with blood clots because of slow flow, but it's a significant minority. And so we end up treating many of these left-sided patients with this May-Thurner process. And these are the ones that we more or less have to stent in addition to removing the clot. And so we've covered the deep and superficial system, the anatomy, and post-thrombotic syndrome. And so access is a big source of conversation in our practice. The standard across the country is to clear the femoral popliteal and or iliac segment if necessary from the popliteal approach. And so single popliteal access is kind of the standard across the country. Dr. Kim has brought in distal vein access, and the idea of distal vein access is to create inflow. And to drill down on that, if we go from here, if we look below the knee, and so if this is the popliteal vein, there are at least 3 major deep veins that feed into the popliteal vein. The rationale is to use one of these veins in order to clear this popliteal segment instead of directly accessing it and leaving clot below the site that you access. So that's the rationale of distal access, and that's relevant for a lot of patients. And so I say this to bring up that popliteal access on the side of the clot and distal access on the side of clot has become rapidly the standard for our practice. Contralateral popliteal access is something that we use on occasion if we're treating a May-Thurner or we're landing a stent. Having the ability to be able to take a venogram or take diagnostic pictures from the opposite side is something that's important because that can help land a more precise stent. And so you'll see us do that sometime. As far as the devices that we use, we started this off with dripping TPA over time. That's more or less gone away. Now it's suction is, I think everybody in our practice is first pull. And so a suction catheter removes fresh clot, meaning clot that's been present for less than 1 week. It's softer, it's easier to remove. And that is a majority of these DVTs are mostly or exclusively fresh clot. And so we all tend to start with suction. And then mechanical thrombectomy is using a scrubbing device, that would be like the ClotTriever, in order to remove more chronic and wall-adherent clot. And so we'll use that. And if we feel like we have to use that or you get distal access, these are the patients that really, in an ideal world, are suited for anesthesia, because mechanical thrombectomy can be a little bit more, creates more traction on the vein, and it can be more stimulating, helpful to have anesthesia. Balloon angioplasty, again, helps treat these sort of webs and areas of potential valvular tethering that can occur. And so as these clots start to absorb and develop, they can create these little webs of scar tissue that tether the veins, and angioplasty is something that's very common that we use for virtually every case. And then intravascular ultrasound is helpful. It looks for residual clot with high resolution, it looks for areas of narrowing with high resolution, and it looks for areas of compression like a May-Thurner with high resolution. So that's more or less every case we use intravascular ultrasound or should use IVUS. Stents are relevant in many of these cases. Sometimes it can be hard to predict. The left-sided iliofemoral clot is more or less a May-Thurner until proven otherwise. In most of those cases, we plan on stenting ahead of time. On the nursing end, I mentioned the rationale for using anesthesia, distal access, cases that have more chronic clot. In cases where we think or know we're going to use the ClotTriever device, it's more stimulating. Also having heparin available is helpful. And then when we finish the case, we think of this as a static procedure with static imaging, but really the amount of blood flow that is constantly bathing the area that we treat has a lot to do with the rethrombosis risk. And so having these patients immediately get stockings in place and immediately get sequential compression devices helps in many ways. And what the stockings do is they create enough compression on the superficial veins to help divert blood flow from the superficial system into the deep system that should be open at the end of the procedure. And the more flow in the deep system, the less likely there is for a rethrombosis or reclotting event. And then the sequential compression devices are very similar. They help stimulate blood flow as if it would be anatomically walking around, and kind of simulate squeezing that calf muscle, which is how we're designed. And so that's helpful on the nursing end. On the scrub and RT end, really the main thing is having all of the devices available. And so setting the case up ahead of time. All of these devices more or less use exchange length wires, and so that's helpful. IVUS, having it in and booted up, is helpful. And then again, the plan ahead of time with respect to bilateral popliteal and or distal access for that patient. I hope that's helpful. Thanks.